Welcome, everyone. I'm Heather Ciccarelli. I'm the Director of the Patient Navigation Initiative here at the American Cancer Society. I use she, her pronouns. The Patient Navigation Initiative is one element of the American Cancer Society's overall strategic investment in patient navigation and provides an opportunity for participants to develop competencies and skills to advance high-quality cancer care. To advance high-quality cancer care through innovative and sustainable models of oncology patient navigation, all the while decreasing health disparities and increasing health equity. Social determinants of health can pose barriers to individualized, timely, and equitable access to cancer care, especially for socially disadvantaged patients. Oncology patient navigation can help overcome health system and patient barriers and facilitate timely access to quality health care. Welcome to the third session of three sessions in this webinar series focusing on the importance of SDOH screening, processes for developing workflow, tracking tools and documentation, and the practice of navigating patients to address barriers to care. Today's session is focused on best practices, taking it from checking the box to meaningful action. Next slide, please. This webinar is being recorded, and the webinar recording will be made available later this week via an email. During today's session, we will not be able to open the mics until the Q&A portion, and we also would recommend using the Q&A question box at the end, and I'll ask the questions for you. Thank you. Next slide, please. I want to take a moment and thank our sponsors. Our work would not be possible without the support of our sponsors. Sponsorship for this initiative was led by AstraZeneca and the Janssen Pharmaceutical Companies of Johnson & Johnson, along with Bristol Myers Squibb. Additional sponsors include GlaxoSmithKline, Genentech, Daiichi Sankyo, Novocure, Pfizer, Santa Fe, and other funders. Next slide, please. On behalf of the American Cancer Society, I am proud to present today's session. Thank you for joining us to hear from our awesome presenters from Rush University Medical Center. These two speakers were invited today to share their day-to-day boots-on-the-ground experience. We will have time for questions and discussion after their presentation is complete. Our speakers today are Lexi Artman and Ebony Henderson. Lexi is the System Manager for the Community Health Strategy and Programs within the Office of Community Health Equity and Engagement at Rush. In this role, Lexi collaborates to develop and implement strategies that result in improved healthcare services, practices, and programs to effectively address identified needs. Lexi's work includes grant management, data management and reporting, and operational oversight and co-leadership of Rush's 30+ member Community Health Worker Hub. Lexi holds a Bachelor of Science in Public Health degree from Tulane University and a Master's of Science in Health Systems Management degree from Rush University, where she served as an administrative project assistant in the Children's Hospital at Rush. Prior to her current role, Lexi worked as a program manager for the CHW Hub and Contract Tracing Program. Ebony is the lead community health worker within the Community Health Equity and Engagement within Rush University Medical Center. In this position, she supervises a team of community health workers who lend their expertise in various areas of community outreach, coordinate community events, and foster partnerships with local community-based organizations. Ebony is also a trainer for internal and external partners for community health workers, mental health first aid, and facilitates workshops for the chronic disease prevention programs. Ebony has an Associates of Applied Science, which she used as a medical assistant previously at St. Vincent's Hospital System in Indianapolis. Ebony also completed coursework through Malcolm X College, receiving her certificate as a community health worker. Ebony is currently working on obtaining her bachelor's degree in public health. Lexi and Ebony are amazing human beings and do great work, and I'm going to turn it over to them now so they can tell you about what they do. Next slide, please.
Thank you so much for having us. We're excited to talk to you all today. Next slide, please. Just like Heather said, I'm Lexi and I'm co-presenting with Ebony today. We're both really, really excited to be here. And we're part of a big team who's able to support all of this great work at Rush and with our Cancer Center. If you attended the session a couple of weeks ago, you've already virtually met Bonnie Ewald, who's a manager of strategic development and policy in Rush's social work and community health department. And we also work with team members from the Cancer Center, including Claire Tobin, who's a manager of social work services for the supportive oncology team, Emily Glaze, who's the director of quality, and Julia Fletcher, who's the manager of quality and accreditation. Our two community health workers in the Cancer Center are Kelly Aguilar and Teresa Martinez, and as you might imagine, this work is really all because of them. Next slide, please. All right. Before we dive into our work specifically, we wanted to tell you a little bit more about Rush, just to paint the picture of the system we're working in. Rush University System for Health is an academic health system. We are based at Rush University Medical Center, which is an academic medical system located on the west side of Chicago. There are two other hospitals within our system, Rush Oak Park Hospital and Rush Copley in Aurora, Illinois. And we also have multiple primary and specialty care clinics, a physician group known as Rush Health, and a health professions university. Cancer care is provided on our Chicago campus. You'll see in that bottom left photo, the building on the right next to our Butterfly building is where most of our cancer services are located and where our community health workers are based. But we also provide cancer care at Rush Copley in Aurora, as well as at Rush Oak Park Hospital and in Oak Brook and Lisle, Illinois. Outside of cancer care, Rush is a recognized leader in health equity, social work, aging, and caregiving. There are many institution-wide initiatives and activities supporting social care, including the central team of community health workers that Heather mentioned earlier. Next slide, please. And why are we here today? We're excited to share specifically about the work that our community health workers, or CHWs, are doing in the Rush Cancer Center to support patients to follow up on their needs related to social determinants of health. We are very lucky that we've had an opportunity to develop and build out this program as part of the American Cancer Society's Navigation Capacity Building Initiative. And just to ground a little bit in the work, if you have not worked with community health workers in the past, we often describe them as bridges or links between clinic and community, and they have a shared connection or lived experience with the patients or community members that they're supporting. This was really important to us when we were thinking about staffing for this program in the Cancer Center, and we've had CHWs in other spaces, both clinically and in the community at Rush, and CHWs have been really critical in this role. Some of the ways that CHWs provide support, which Ebony will get into in just a minute, is by building rapport through shared cultural and lived experiences, like I mentioned earlier. The CHWs who are in the Cancer Center have both been caregivers for cancer patients prior to joining us on our team. And CHWs can also help connect patients with health promotion and socialization programming, navigating relevant community resources, and being a part of that team that we mentioned earlier to escalate and refer patients to clinical licensed social workers and other care team members. Our team specifically is based in person in the Cancer Center, located again on the west side of Chicago. We're supporting the radiation oncology and infusion clinics right now. And we are working with many interprofessional team members, especially closely with the supportive oncology team of social workers and the nurse navigators. Next slide, please.
Yes, so we got started in our Cancer Center actually last year on February 14th, Valentine's Day, as we joined the Cancer Center and working in conjunction with the nurse navigators, RNs, and social work team in both the radiation oncology and infusion clinics. The CHWs interact with these patients in radiation oncology telephonically, and they follow the process that is a bit more automated, if you will. So what typically happens is a patient is seen in radiation oncology. They can do their SDOH screener or social determinants of health screener either via MyChart or if they're unable to do so via MyChart or they're not signed up for that, we can get them to take the screener on an iPad when they do their check-in. From there, an RN or an MA will review the screener. If there are any positive needs, that person will then create a referral to a community health worker in our Epic system so that we can follow up with them telephonically. That CHW creates an individualized ERX, which we call like an electronic prescription for resources via our NowPal or Unitas platform. It's currently NowPal. They will be merging with Unitas very shortly. And that's based on a patient's needs and geographic location. Referrals and follow-up needs are all documented in Epic. But as you can see, we don't just see patients in radiation oncology. We also see them in the infusion clinics. And this is way different. This is definitely more in person. And we make sure that we give the same type of resources to both patient sets that we see. So the actual CHW will check a schedule, the actual clinic schedule, to see what patients need to be seen. And we identify those as new patients to the center, new treatments for cancer. Then they coordinate with the RN through a secure chat in Epic to find out when is the best time for them to come and see that patient, as we don't want to interfere with the infusion process or folks getting connected with the doctors and so forth. So they go ahead and the CHW will go to the room. Once they're cleared to come up, they'll sit with that patient, ask the SDOH screening questions, and they'll go through the process of making sure that that person is getting an individualized ERX through that platform that I mentioned through NowPal Unitas. And we'll follow up on that process. There are some challenges sometimes with this process in person, because as you can imagine, we're dealing with people that are feeling all different types of emotions as they are new cancer patients. They may be feeling ill due to the treatment and sometimes have adverse reactions to those treatments. So we as CHWs have to be very flexible in wanting to make sure we are being patient-centered in our care. We don't push the issue of trying to complete a screener in person if that's not where the patient is at that time. We will, however, follow up and give the patient a call the next day. So we will pivot where it is necessary. And again, all of this process will be documented in Epic to make sure that we are keeping track of everything that is going on. Next slide, please. And so our resource coordination, after we've completed that screener, we now want to make sure that we are going through the ERX, as I mentioned before, for each individual patient, making sure that it's relevant to that individual. So patients are given this ERX through their preferred route. It can be either text, email, or we can print. If it is going to be sent via email or text, the patient is asked if they can make sure they've received the message. And once they've received it, we want to make sure that they can open the link so that they get access to the information that they need. We also make sure that the resources are relevant to the patient, meaning that it is, if a patient is being treated for a type of cancer and they're unable to work, we don't want to provide them with job readiness resources because that's not relevant, right? We want to make sure that we are getting the patient exactly what they need, as closely to what they need as possible, and not providing them with anything that would be outside of a range that they could reach. So we typically have the resources sent to them within 5-mile radius of their home. All patients are connected with partners to support them with their wellness and support, such as our Wellness House or Waterford Place. These are support systems that help patients going through cancer treatments with support groups, art, culinary, massage therapy, all different types of resources that can be accessed for these particular patients. And most of these are definitely free of charge. We also refer them to self-management courses we offer as like our Cancer Thriving and Surviving workshops. These are focused on patients that are going through cancer or have survived it, or are caregivers. We want to make sure if a patient is food insecure, that we are setting them up with one delivery for the next 3 months of food to be delivered to their home. The first month they will receive fresh produce. The second and third months, they will receive fresh produce as well as frozen protein to help them in supporting that gap with the food insecurity. We'll also make sure if they need to have resources around EBT cards, SNAP benefits, that we assist them with that as well. Insurance assistance, if we have to, we can connect them with a SHIP counselor for Medicare, as well as our public benefit specialists that can assist them with public benefits. And if not, then we also have patient navigators that assist with other insurance routes. We also partner with agencies that can help them with temporary assistance, such as rental and utility assistance, as well as some grant programs, such as Christmas Without Cancer. Next slide, please. All right, so here's an example of what our screen would look like in Epic. Please note this is a test patient. No PHI has been used for this presentation. And we're going to go through this process. This would be an infusion patient. As you can see here, there are 4 circles to the left there. They all have a different icon. Those represent the needs of the patient. So this patient has a need for transportation, food insecurity, interpersonal safety, housing insecurity, and utility needs. What we would do as far as transportation, we use several different routes. One is our PACE paratransit transportation system. We also use the ACA's Road to Recovery, as well as that individual's insurance information. We've been fortunate enough to be able to support patients with transportation needs by providing PACE vouchers for the patient as well as their caregivers so that they can have 5 free rides to get to and from their doctor's appointments. We also have parking vouchers for patients that need to actually drive to the cancer center. They can receive 5 vouchers for that as well. As we know, Road to Recovery is a free service and is very useful to a lot of the patients that we've served. In regards to the food insecurity, again, we connect them with a EBT card if they are qualified, and our Food is Medicine program, which is the 3 deliveries to the home. Utility assistance would be CEDA, which is Community and Economic Development Association of Cook County. They offer payment plans or one-time grants to assist patients with paying their utility bills, their electric bill, gas bills, things of that nature. And if there's a housing and interpersonal safety issue, this is what we would escalate to a social worker. If it is an immediate need, we would escalate to a STAR social worker, who is someone that's on staff that can be paged for immediate distress situations. And all of this can be provided through that NowPow ERX that we would bring over to the patient in their preferred form. Next slide, please.
All right. Thanks, Ebony. We want to share a little bit more about some of the resource and referral partnerships that we have at Rush and that have made this work really possible for us. Ebony's touched on a lot of them already, but to give you a little bit more insight, we are lucky, just like you've seen, to leverage an electronic health record. We use Epic at Rush, and we have the resource portal NowPow available through Unite Us. Like Ebony mentioned, Unite Us has acquired NowPow, so we are in the process of that full integration. But the portal has been really helpful to us in being able to share resources based on the social determinants of health screener, and it's actually embedded right into Epic. We also have some specific referral partners. One of the wonderful benefits of NowPow and Unite Us is that we are able to place closed loop referrals with certain partners. And this means that the impetus is taken off the patient to be reaching out to those resources, and the organization itself will actually follow up. And so a great example of this, like Ebony was saying, was with our Top Box Foods partner. So when we put a closed loop referral in NowPow or Unite Us for Top Box Foods, they will follow up with the patient to confirm their delivery date, delivery address, and let them know when that box of produce and protein will be delivered. We also have been able to provide, just like Ebony mentioned, vouchers for PACE paratransit, as well as parking vouchers for the parking garage at our new cancer center. And then we also like to talk about Waterford Place. Waterford Place is a cancer resource center that is located in Aurora with our Rush Copley Hospital and Cancer Center location. They provide a wealth of resources to cancer patients and their families. And although many of our patients are from Chicago or located closer to Chicago, they do offer many of those services virtually. So we're able to place direct referrals there. And this is also not an exhaustive list of partners. Those are just the referral partners that we've worked most closely with for this patient population. Like I mentioned at the start of this webinar, Rush also has many different social care programs across the institution. Two of the ones that we work most closely with are Rush Generations, which includes those health promotion and disease prevention programs like Cancer Thriving and Surviving, and also the Rush Caregiver Initiative to support burdened caregivers. We're able to refer to those programs through the Epic system or Unite Us actually as well. And because we work with their program managers, sometimes we're even able to directly send an email. And then finally, we are members of a care team. So CHWs refer patients to other members of the team depending on the needs that are identified. We'll get into this a little bit more when we go to the next slide, but social work, nurse navigators, and financial counselors are some of the people, the care team members that we are referring to most often. Next slide, please. All right. This slide is a synopsis of the different escalation pathways that our community health workers have within the Cancer Center. I do want to give a disclaimer as we're sharing this slide that these protocols and processes are developed really specifically for our Rush team within our Cancer Center and should be very carefully reviewed and tweaked for risk and liability at any other institution or within other programs. With that said, we are mindful of the scope of work for community health workers. We'll get into training a little bit at the end, but community health workers are not licensed social workers, and they have or nurses, so they have a different scope of care. We are within the Cancer Center still using the distress screening and the distress thermometer. Our team does not complete that screening, another team does, but sometimes those needs do come up when a community health worker is speaking to a patient. So we want to make sure that they have all of the information that they need to be making the appropriate referral. You can see here on the left the type of outstanding need that might be identified, and then on the right, the escalation team. We are working very, very closely with our Cancer Center social work team, as well as supportive oncology. There are social workers within the supportive oncology team, as well as other navigators, including that STAR distress social worker. To walk you through it, if a community health worker identifies mental health or substance use, they will place an order through our Epic system to refer to the Cancer Center social work team. And we also refer for any needs related to housing. If a patient has 3 or more positive social determinant needs, taking out that employment question, which we've had some changed language around, then the community health worker will also refer to social work for more complex case management. I mentioned earlier that we have a program for caregivers at Rush called the Caregivers Initiative, and we are able to refer any burden caregiver for a cancer center patient to that program. The program provides a lot of different support and again, really just focuses on the caregiver component of it. And we also like to place a referral to the Cancer Center social worker so that they're aware of the caregiver's current situation. Complex financial concerns are also an escalation. Insurance issues have their own set of follow-up. So we do have a SHIP counselor for Medicare concerns in the Cancer Center. And then for billing or prescription assistance concerns, we have financial counselors and coordinators. Ebony has noted too that questions around billing are the most common financial concern or question that our team receives. We often come across in-home needs as well. If it's related to transferring to a facility, whether that's a SNF or assisted or independent living, or requesting homemaker services, then that's where our social work team will also step in. If it's an in-home need related to home health or durable medical equipment, our CHWs refer to the patient's oncology nurse navigator. And any concerns around engagement or capability, like disengagement or ambivalence with the care plan, we would involve both the Cancer Center social worker and the patient's primary oncologist and nurse navigator. And then finally, high-risk situations. So if we're identifying a need that's really emergent related to de-escalation, or if there's risk of harm, abuse, neglect, domestic violence, or other safety concerns, then we page the STAR social worker to come see that patient immediately. Next slide, please. With all of these resources and all of the different systems that we have, it's absolutely critical that we're including patients and the community to get feedback on what's working, what hasn't been working, and what they'd like to be seen differently. If we're not connecting with the patients in their community to understand what they need, then the resources aren't as helpful as they should be. So for our team specifically, we worked with Rush's Community Engagement Council before we even started the navigation and social care coordination work funded by American Cancer Society. Rush has a community engagement council through our Rush Generations program, and it's a volunteer group of older adults from the Rush community. Outside of this specific request, they also provide feedback on Rush Generations and other programs. They participate in focus groups and inform of community needs. Specific to this group, many of them either had been cancer patients or were caregivers for cancer patients. So we attended one of their monthly sessions and kind of outlined, here's the program plan that we are thinking about. We want your feedback. We want to know what is missing, what won't work. But we also asked them about the resources we were able to provide and, again, what might be missing or what might not work for that specific population. We have met with them. We meet with them on an annual basis. So we just did our one-year review with that group and got more feedback. And in addition to that, we're asking patients for feedback in an ongoing basis. So I'll get to this a bit with an example on the next slide, but we are regularly asking patients if the resources we shared were helpful, having discussions about how they worked when they were used or why they weren't being used, and using that to inform changes to our program and where we go next. Okay, next slide. All right, from here through the end of our presentation, we do have a few patient impact stories that we included. We feel that these are important to showing why we have our processes in this way and how they've worked. So I'm going to read this one. Thank you, Ebony, for letting me share. But this story speaks a little bit to how we've incorporated patient feedback to revisit some of the resources that we provided upfront in more recent days. All right, so Ebony said, I recently spoke with a patient during a reminder call for their food delivery. Before ending the conversation, I asked if there were any additional needs at this time, and the patient identified a need for transportation to their medical appointments. When I spoke to the patient about potential resources, I first offered him Road to Recovery. He declined. I offered him a different resource that we have available, the PACE paratransit ride vouchers. He declined this resource too. I asked the patient if he would mind sharing why he declined, and the patient said that he needs his caregiver to attend his appointments with him, and both of these resources are just for patients. This was a barrier to using the resources available that our team had not anticipated. I shared this information with our team, and we connected with PACE to see if the patient can book 2 seats when coordinating rides. We are now able to provide patients with 2 sets of PACE vouchers to allow their caregiver to ride with them. If I hadn't asked the patient why they weren't interested in the resource, then we wouldn't have been able to remove this barrier. This shows the importance of listening to patient feedback to effectively provide resources. I think that last couple of sentences really sums it up, but this was something that we hadn't even thought of was if the patient needs someone to go with them and transportation is a barrier for them, how can we make sure that they have everything they need to get to that appointment? So this was very recent. In the last month or so, we've been able to update this process, but this is one of the ways that we're seeking feedback to make sure that, again, the resources are relevant and supportive to the whole patient. And I'll pass it back to Ebony for the next slide, please.
Thank you, Lexi. So our routine screening for social needs. So we screen all patients that are new cancer patients to the cancer center because our cancer center sees more than just cancer patients. So if we have a new treatment for chemo or something to our new SIM for radiation oncology, those patients are being taken care of with their routine screening needs as they come in. But we also rescreen patients every 6 months. So I do need to preface this by saying that we do prioritize our team's workflow. And due to a little bit of a staff change, we had to prioritize our working, making sure that we are seeing patients in the infusion clinic as our first priority, completing referrals from radiation oncology as our second priority, and rescreenings are happening when time permits so that we're doing that in between when we have a little bit of downtime, okay? So we do check in with the patient to see if the resources that they provided them previously were helpful. We rescreen the patient and provide them with any additional needs that they may have at this time. If they have found that some of the resources didn't work for them, we ask why and take note to see if we can troubleshoot that problem. Sometimes patients misplace the list, so we are always willing to provide them with the information again. We also provide the patient with our direct contact information, so they have a phone number to directly interact with their particular CHW, and making sure that they can contact us later if they realize they have an additional need or if they need help navigating resources. So we don't just provide them with the number to PACE paratransit. If that patient does not feel comfortable making that phone call, we actually will ask them, would you like for us to assist you with making that call? And sometimes they do feel a little bit better and they get a little bit of reassurance from us being on the line with them to make sure that they're crossing all the T's and dotting the I's, right? So we want to make sure that we're being supportive in more than one way, not just providing resources, but actually being a person to help them advocate for the things that they need during this time of going through a journey of cancer. So next, I will read a patient story that is surrounding our rescreening from one of our CHWs. Next slide, please. Okay, so this story comes from our CHW, Teresa, who is boots on the ground day in and day out. And Teresa stated, about 4 months ago, I made a call to a patient to conduct a 6-month rescreening on the SDOH screener. The patient screened positive for needs related to food insecurity, housing, and interpersonal safety. I was happy to connect the patient with resources including top box delivery service and a list of food pantries near her home. I was also able to connect the patient to a social worker for her housing insecurity due to her financial situation. The patient shared that she and her daughter don't see eye to eye, and that her cancer diagnosis has made things worse for her relationship with her daughter. Although the patient stated that she doesn't like to talk about her cancer diagnosis, she opened up to me. I thanked her for trusting me and reassured her that I'm here to help if any other questions or concerns come about. The patient noted that she would benefit from talking to a counselor about her experience. Speaking to a social worker helped the patient. The social worker provides emotional support and reflective listening, and also discuss free one-on-one counseling for the patient through the wellness center. Through the wellness house. The patient agreed. I truly enjoy doing rescreenings because anything can change in a matter of months, especially when a patient is dealing with a cancer diagnosis. So here we can see how the CHW works with multiple departments to facilitate the needs of the patient. Here, Teresa has used her training of empathy and active listening in creating a safe space for the patient to allow her to open up to her. This is the kind of relationships we want to build with our patients. And we want them to open up and tell us about their needs so that we can assist them as much as possible. Next slide, please. So CHWs, as Lexi mentioned, do go through extensive training. So we have training onboarding here for 2 days, which I am a part of. We make sure that they complete 2-day training on core skills and competencies. This is in alignment with the C3 competencies, and we will be able to provide that website for you around what those 3C project organizational rules and competencies are. Lexi, would you mind being able to copy that into the chat, please? Thank you. And we want to make sure that they not only get those core competencies, but we also are connected with our chassis training group. Here is the Center for Health and Social Care Integration here at Rush. That basics of, do you have it? Okay, great. The basics of community health, social determinants of health screenings, chronic conditions and benefits and insurance. We want to make sure that they are informed about stress and trauma and mental health, communication and engagement skills, as well as navigation and advocacy skills. And last but not least, we want to make sure that they are administrative skills and they're able to communicate with people effectively. CHWs are trained in our EHR or EMR system, which is EPIC, Unitas, NowPal, and escalation protocols specific to onboarding and specific onboarding sites for, in particular, like our cancer center. We also have patients, CHWs in our ED system. So they would be specific onboarding trainings for those departments. We also offer shadowing opportunities to provide CHWs before they work independently. So before we rolled into the cancer center, those days I was actually boots on the ground with my team. I made sure that I was there to support them. This is a new space. I wanted to see how things were going. So I actually, typically I have more than one team that I support, but I actually worked with them for 2 straight weeks to make sure that I was there as a support system so that they would know we could work out any problems that we may have encountered or didn't anticipate encountering. Okay. So next I will read another patient interaction story from another CHW. Next slide, please. All right, this impact story is shared by our CHW, Kelly. Earlier this fall, I received a referral to follow up on prior SDOH screener for a patient who previously screened positive for housing insecurity and financial needs. I spoke with the patient and they confirmed that they were already receiving help for those needs from their social worker. To better assist the patient, I believed it would be beneficial to conduct a SDOH rescreener to update the patient's answers. When completing the new screener, the cancer patient screened positive for interpersonal safety. The patient was in a domestic conflict situation and was fearful for their safety. Having a cancer diagnosis, receiving treatment, and facing other social needs along with feeling unsafe in their household can be a lot for one individual to handle. Using my mental health first aid training and remembering the escalation protocols, I paged the STAR social worker. The patient expressed appreciation for connecting them to the social worker and was grateful for the resources I gave them. The patient is now receiving help and is feeling safer. As a community health worker, I take pride in knowing my patients feel safe, supported, and have access to resources that they need. So again, we cannot emphasize enough how we want to make sure that the work that we're doing is patient-centered and focusing on the needs of those patients and how we can support them best at that particular time. We want to make sure we're meeting the patient where they are. And as community health workers, we are always coming up against obstacles at times. So one of the things that I am infamous for saying is that a community health worker has to be fluid like water. You have to be able to change as the plan changes. We have to be flexible in this work. And I am grateful to not only Kelly and Teresa, as they are amazing community health workers with my team. I'm also grateful for Lexi and leadership for allowing me to kind of help spearhead this initiative, as well as for the American Cancer Society for helping fund us in this space so that we can support these patients. As Lexi mentioned, each one of the CHWs, Kelly, Teresa, and myself, cancer is all near and dear to us in different aspects. And so it is just very fulfilling to be able to continue to provide the support and do this work. And we thank you all for your time and listening to us. So the next slide, please. Thank you so much. And I'm sure we have some questions and we're willing to answer those.
Thank you both. You did a fabulous job. I wrote down your quote, fluid like water, because I think anyone in the navigation space, or really for that matter, anyone involved in cancer care, fluid like water is really what you do need to be. And sometimes, right, you have the resources and ability to do that. And sometimes it's a little harder. But thank you for sharing all that you did today. We do have a lot of questions, and some of them are a little bit more around your Epic system. So I think probably a lot of people on the phone saw your listen to how you're able to make referrals and really wanted to have that happen at their institution. So one of the questions is kind of two parts. Do you have any special modules that have been added to your Epic? How did you integrate the POW Now system into Epic, sort of in theory, because I'm sure the technical answer is beyond most of us. And for CHOWs who don't have access to a system like Epic or to an EHR, EMR, what would you recommend?
I can maybe start with some of the technical pieces, and Ebony is definitely the right person for this last question. But in terms of integration, Heather, you nailed it. Neither of us are Epic or IT experts, but we do meet regularly every week with the NowPow or Unite Us team. And when they first got it integrated within Rush's Epic EHR, I know it was a big process to be able to do that. So I can't speak to all the technical pieces, but it is a formalized partnership, and we do have a license with that organization to be able to integrate. NowPow and Unite Us are definitely the experts on that, and our colleague Rachel Smith has been doing that work since it first started. So I don't have a super helpful answer other than we did partner with the organization directly to be able to do that, and leaned really heavily on our IT colleagues. In terms of the oncology module, Ebony, I don't know if that's something your teams have seen. I'm not familiar with that module, but I can certainly check if Ebony hasn't experienced it, check in with our social work colleagues who would probably be able to provide more information and confirm or deny for you.
Yes, we haven't really seen the oncology module. And if there's something that's going on, I think the question was if they didn't have an EMR system, how would that go about? We actually don't just do, we have adapted our SDOH screener. So for instance, a lot of times we do this work in the community because we do community events and screenings and such in the community. We actually put that on paper. So we have a paper screener that's the exact same as it is in Epic. And then we transcribe that back into Epic, into that patient's file. But yeah, it's a little bit different. You can, certainly go back to old school with the paper and pen, but I'm not exactly sure what system you would have, but it would be something that you can integrate over into a regular paper file.
All right, thank you. I know that's kind of a complicated question and how we document and the systems that we use and whether you have Epic or Cerner or some kind of add-on or some integrated AI program certainly makes a big difference and is one of those problems that we're not individually able to solve, but certainly is a challenge that many systems face. Other questions have to do with training and certification. So I know you talked about what you do to train your CHWs as they are onboarded. Is there any kind of certification or licensing in the state in terms of requirements for your CHWs?
So we are in the state of Illinois. We don't yet have formalized certification requirements to be able to practice as a community health worker. We are planning for that. We know it will be coming, but we do not require we do not have a formal certification requirement yet. I saw Ebony come off mute. I know she will have great information to share about the program that some of our team members have gone through at Malcolm X College, which is a CHW certification, but kind of in lieu of that requirement. And because not every team member has had a chance to go through that yet, that's part of why we have the 2-day training, which is provided by Rush's Center for Health and Social Care Integration and aligns with those C3 competencies as a kind of a baseline. And then we provide ongoing other training opportunities based on certain topics as well. But many of our team members, we've been able to fund some team members to go through the Malcolm X CHW program. Ebony actually completed it before she came to us. So she's a little bit more of an expert and can share information about that.
Yes, the Malcolm X program, when I went through it, was a kind of intense 16-week certificate programs. So I want folks to understand that Illinois hasn't gotten the certification yet. So it is a little bit different. It's a certificate program which went through the 5 different classes, foundations to community health work, mental health, epidemiology, nutrition, as well as a field experience. So you have to also do 80 hours of a field experience so that you can get the certificate. Amazing program. It was a great foundation for what I'm doing now. And as Lexi said, quite a few of us have completed the program, and some others have not, but it is a good basis and foundation for being able to make the stepping stones, because I came in as a contact tracer and now I'm a lead. So I've moved up the ladder pretty quickly. Next question.
Thank you. Some of the other questions really have to do with the population of patients that you serve and how you get referrals, whether you ever get referrals or other members of the team, if they get referrals directly from the oncologist, if they're ever making referrals directly to the social workers, patient navigators, or the CHWs.
So we get referrals from everybody. So we can get it from an RN, we can get it from a social worker, we can get it from the actual oncologist. It is an open referral system that they can just let us know exactly what it is that they need us to do with that patient. And sometimes it's not necessarily so clear, but we'll communicate with that individual to make sure that we are providing the information that they need for that patient. As far as patient population, in our cancer center, we work with folks only diagnosed with cancer as it is part of the directives of the grant. But in other spaces, we work with patients regardless of what their medical background is. So in our ED system, we have community health workers there. We have a program called E3 that's dealing with hypertension, diabetes, depression, and substance misuse. Help me, Lexi. I know I'm
Yeah.
forgetting something.
We have some team members in school-based health centers and our emergency department. We're lucky that we've been able to pilot CHW programming across a variety of different spaces.
Yeah, and we're really excited about how well you've been able to integrate it into the oncology space and to work with the other patient navigators. And I certainly heard you say that there's enough work to go around, that there's really more work.
Yes.
You know, that the need exceeds the resources. But I think people always worry about either scope creep or really defining who does what. And I'm sure that your system isn't perfect yet and that it has evolved over time. Could you talk briefly about how you determine sort of who would do what work?
Yeah, when we first learned of, well, I guess taking a step back, our team has been working with the Cancer Center for almost 3 years now. Initially, we got connected around some of the community certification requirements, and then we were really excited to be able to partner on this specific grant initiative. And so when we were collectively writing this proposal, we met with managers from several different teams and directors from several different teams in the Cancer Center to hear about what gaps existed. And from there, knowing what our team of community health workers is able to provide and where they really thrive and excel, we were able to match make a little bit to fill in the pieces. We definitely want everyone to be kind of working at the top of their skill set and doing what they're really experts at. And we don't want anyone to feel that they have to work outside of their scope. So that's part of why we have such robust escalation criteria. But I think part of it was just really taking a moment to say, where is the social work team at capacity? And is there anything that a community health worker could help with? So specifically for us with this program, the Cancer Center team was getting ready to roll out social determinants of health screening. The nurse navigators were completing the screening when we first started, but they were concerned about time and expertise to be able to connect patients with all of the resources. So we heard that and we said, oh, we can certainly help. And that's how our team came to be. I think on an ongoing basis, we meet monthly with all of the different members of the team. Ebony meets with the CHWs much more regularly than that, as does Claire, our supportive oncology social work manager. And if there are ways that CHWs can help and if they have time, and then we kind of adjust from there. So for example, one of the things we're working towards is having CHWs become trained to help with homemaker services and be able to manage that process for patients as well. Ebony, what else would you add?
There's so many things. Oh my goodness. We are just in a good space where we are able to support these folks. I think you pretty much hit all of the bases there, Lexi. I don't think there's much I could add on to it because, you know, she's such an amazing manager.
Fantastic. Another question that came up and is, how do you fund or pay for your food program? That box, that wonderful box that you're able to provide patients.
Well, that's all thanks to you right now. We do have some funding through this American Cancer Society navigation grant, where we were able to provide funding for specific resources. So just like we were saying, we took in feedback from patients. We also looked at the data from the first 6 months of SDOH screening in the Cancer Center and looked at what needs were most prevalent in food, as well as transportation and general financial needs were at the top of our list. We are very lucky to work in a department at Rush where the Food as Medicine program is based. Our amazing colleague Julia Bassett leads that work, and she too is completely grant funded. So kind of separate from the cancer patients, she is managing several different grants to be able to provide those top box or 40 acres food delivery products to patients, mostly from primary care, but also from other clinics across the institution who are in need. So it's a lot of seeking out grants.
Excellent. And, you know, you have to acknowledge that the grant funds from the American Cancer Society are limited and they're not going to last forever. So what evidence are you collecting to make a compelling case for additional funding or continuing that program or having your institution build that cost into their budget going forward?
Great question. We are able to, so when I think specific to the food referrals, we are able to track the number of referrals that we place to the partner through NowPow. So that is one way, is even just simply the number of referrals. Those follow-up SDOH screenings will be able to track if the food need still exists for those patients. We do not just send the box. We always also counsel on SNAP if someone is eligible for that. So it's kind of, again, providing that whole person care, but collecting information on those referrals. And also, just like you heard here, the patient stories to be able to say, yes, this, in addition to seeing these numbers, this has made a difference to this person.
Thank you so much. And we're going to need to wrap it up. But before we do, I do want to just clarify that the American Cancer Society Road to Recovery program does allow for a caregiver to accompany a person with cancer to treatment. And certainly if you have any questions about who is eligible and what services are available, you can always go to our website, do live chat, call the 800 number, reach out to your cancer center partner. So there's lots of ways to make sure that you're the most up to date on our programs and services that we offer. And I would like to just take a minute and thank our sponsors one more time. I also want to thank our two panelists today, Lexi and Ebony. You were fantastic. And you will all be receiving an evaluation. I encourage you to please take a few minutes and fill it out. Your feedback helps us to plan programming to support the development of high quality patient navigation programs. We want to hear what you'd like to learn more about so that we can provide you with quality programming to meet your needs. And we will be sending out a link to today's recording. And if you would like a copy of the slides, you may request it by reaching out to the navigation mailbox, and that information will be included in your follow-up email. Thank you very much, everyone, for joining us today. Have a wonderful afternoon, and we really appreciate your time and hope you enjoyed this as much as I did. Have a great afternoon, everyone. Thank you so much. Thank you. Thank you.
Thank you.